I'm Rick McGuire. I'm the executive editor of CardioSource Interventional News. We're talking at the SCAI meeting, and I am with Dr. Manny Reyes and Dr. Prakash Balan. And we're talking about FAST-PCI. And the first thing is, tell me a little bit about FAST-PCI.
Sure, Rick. So one of the concepts that we've had since first day of medical school is that when dealing with heart attacks, the time is myocardium, which makes sense.
Right.
So what we want to do is there's an artery that's involved in the blockage of the heart. We want to open up that artery as quickly as possible. And nowadays we've realized that we are limited in how fast we can start our EC going, recognize the EKG is abnormal, get the cath lab activated, get the cardiologist in the lab, get their staff in the lab, technical aspects, getting into that artery and fixing that artery open. And we've done really well. We call that a door-to-balloon time, and we've decreased that pretty significantly. But we've started to realize that that's not the entire picture. We're really, when we focus on that alone, we exclude the pre-hospital period, which is crucial to the total ischemic time, the time before the hospital and the time after the hospital, from the time of onset symptoms to the time the artery is open. So what we try to do with the FAST-PCI and the concept of FAST-PCI is to try to get that artery as quickly open as possible in a safe manner.
Right.
The people have tried in the past of using different medications to try to open that, including clot-busting medications, the layman term, and different medications to try to get that open, but have noticed it with bad results, essentially a lot of bleeding, trading off a lot of bleeding, as opposed to opening that artery quicker. One of the concepts that we've been working on now is using a kind of a hybrid approach of this system, is where we see the patients on the field. It's a cooperative of EMS personnel, the emergency room, and the cardiology team, where the EMS does a great job of recognizing there's a heart attack, do an EKG, are able to transmit that EKG to the emergency system, to the ER, or to the cardiologist system directly. We now get them on our iPhones quite routinely. And we can say, yes, it is a STEMI, it's a heart attack, activate the cath lab, initiate the sequence. At that time, in our facility, we're able to have the opportunity of the EMS giving usual antiplatelet therapy, which we would give aspirin, clopidogrel, an anticoagulant such as heparin, and on top of that also start giving a reduced dose of fibrinolytic. The whole idea, or clot-busting medication, the idea of that is to start working on that artery before they even make it to the hospital or the cath lab, so that we're minimizing the time that that artery has been shut down completely. And what we've noticed is that by the time they get to the cath lab, that artery a lot of times is already open. Of course, we still have to go in and do our final manipulations into the artery, but we know that the artery is open. That means the total time that's been shut down is less, and our outcomes are looking very favorable without sacrificing safety.
So this particular study, the pilot I recall, goes back to 2007.
That is correct.
And how many patients are involved at this point in time, and what are you finding?
Well, really there are two arms to what both Manny and I have been working on, and these arms are really fortuitous in terms of how they came to be. We looked at 253 patients in the FAST-PCI arm and 124 patients in the primary PCI arm. The reason we have these two arms is right around 2009 there was a national shortage of Retaplace, which is the fibrinolytic that we were using. As a result, we have two groups now, one in the Retaplace available era, and then for the last couple of years without Retaplace. And it turns out these two groups are our standard STEMI population, so they're actually very similar in terms of their baseline characteristics. Although not randomized, they are roughly comparable groups. And using that population set, we've been able to compare FAST-PCI to primary PCI, and as Manny has pointed out, opening the artery as quickly as possible does in fact provide a mortality benefit without taking on the excess bleeding risk that had been seen in the early studies, things like Gusto 2B, with excess bleeding with full dose fibrinolytics.
What's the difference? Is it really the dosing? I mean, is that the thing that's making the fewer strokes and the fewer bleeding problems that you saw earlier?
That's a great question, and a lot of people have been trying to figure that out for a long time. One of the things that we've been noticing now is it's a total ischemic time. One of the things that we mentioned in my paper that was, or my abstract that was presented at this convention, and along the topic, the same the one that Dr. Balan has presented, is that it is all about ischemic time, total ischemic time. What I did on my group of patients, I've actually subdivided them into total ischemic times. We've noticed that FAST-PCI has its best benefit if the total ischemic time is less than 120 minutes. After 120 minutes, we see that benefit awash. It doesn't matter what we throw at it, it's still going to develop large infarcts, which we've been measuring by MRI. So it's all about ischemic time. So now if you extrapolate that and you go back to the original data of FINESSE, all these big thrombolytic trials, you notice that their average ischemic time actually extended beyond 120 minutes. So it made sense. It's not, these data do not conflict. They actually are congruent. Right. The total ischemic time was larger in that data, and it makes sense that when we have ischemic times that are less, we do provide that extra benefit. So in our data, in our population, we've said that FAST-PCI, when it is performed with ischemic times less than 120 minutes, does provide the benefit. After that, the benefit is not so much.
So what do you recommend at this point in time?
We've been using a single fixed dose of Retaplace, 10 units, administered upon recognition of ST elevation myocardial infarction, and then as quickly as possible get the patient to the cath lab, perform urgent PCI. The idea here is to use the fibrinolytic to get flow down the artery. That reduces the ultimate infarct size, which is what Manny's shown with his MRI study. And then, once we get them into the cath lab, fibrinolytic, just restoring flow, is not by itself enough. There is a ruptured plaque there that has to be treated, and we get that treated as quickly as possible with PCI.
Now, Richard Smalley, who is one of the co-authors on this particular paper, correct? On both of these papers. Now, he wrote an article in JACC. It was an editorial, I think it was 2009, and you can go back and see that because that really outlines the importance of ischemia time. And for Cardiosource Interventional News, I'm Rick McGuire.